It is my great pleasure to first of all introduce our first speaker, Professor Uwe Dulleck, who is Professor of Economics in the School of Economics and Finance at QUT, Queensland University of Technology. His expertise is in behavioural economics and has been recognised through the award of several ARC linkage grants and discovery grants exceeding $10 million. His research, especially in expert services and in credence goods, has been applied in health, focusing on medical economics and behavioural barriers and enablers to access and adoption of new therapies and procedures. And today he's going to discuss the role of health economics and behaviour change in understanding and improving health inequalities. So, welcome.
Thank you very much. And I think the bar is high after we heard a lot before about challenges to achieve health equity. I would actually like to start as well to acknowledge the Turrbal and Yagara people as the traditional owners of the land where we meet. QUT, we always say these have always been places of teaching and learning. And when I actually first joined, and you can hear from my accent, I wasn't born on this country, I moved here. I asked an Aboriginal collaborator, co-author on some of the work we do. Where does this welcome to country come from? Is this just us white people who introduce something, or is there some more to it? And she actually told me that there are two stories, and I heard these two stories a couple of times. The one is, it's about if you want to learn from other people, you need to tell them where you're coming from and what your values are and what drives you. So I said a little bit, I came from Europe, I'm originally from Germany. I'm also an economist. That's maybe more interesting. And I wondered, why did I get here? I looked at the program committee and I saw, okay, I work with 3 people that are on that committee, and had a couple of discussions of other people that are sitting here today. So maybe that explains why you see me here. But the second thing was as well that the welcome to country, or the acknowledgement of country, is about telling each other what are the laws of the land. And I find that quite interesting as well. I think we all come from these different disciplines. I'm encouraged to see this event, and thank you for inviting me, because I think we can learn from each other as well how we navigate this territory. That's a little bit what I heard this morning as well. Now, representing the best center at QUT, I'm one of the co-directors for another 4 weeks. Then I moved to Canberra. I try to convince you that behavioral economics has something to say in this space. And let's see whether I succeed or not. You can tell me later as well. So what do we try to do? This is the BEST Center. What does BEST stand for? It's Behavioral Economics, Society and Technology. And the idea was to bring together researchers in economics. We heard a little bit about economics this morning when we talk about equity, but also business, maybe much more applied economics, and combine that with expertise in health in particular, but also from other fields of engineering. And we work a lot also with data scientists and so on, and really see what we can do to actually combine these different tools to achieve progress in society, but also at large, but also in smaller contexts, at the same time trying to push an ambitious research agenda. We were successful, which is quite nice, and again, 2 or 3 people on the program committee were actually with us on this bit to actually say it may be interesting to use behavioral insights to actually understand innovation uptake, and that's where I want to start. In health, we look at agriculture as well, and we look at the digital world. It's just where we see this type of applications to achieve innovation uptake. So very often we heard, at least I heard, my bias, my focus, we heard this morning that we have very often therapies. We know how to cure people, and we heard as well that we don't sometimes understand why aren't the people on the ground using them correctly or to the full potential? Why don't patients engage with the tests and the type of treatments we provide? And you all know this type of questions, either as practitioners, whenever I talk to practitioners, we have this type of discussions, or you look at it from a public health perspective. It's one thing to develop solutions, it's another one to get them actually used and used to the full potential. So what I want to do is what I call a bit the bitter argument that we had, behavioral insights for technology uptake, is to look at this problem of health equity through a lens where we say, well, we can use what I would call behavioral economics. You can call it your field of research, and I think you have different ways to talk about it. Can we talk about technological barriers and or enablers? Can we talk about economic barriers and or enablers? Can we talk about behavioral or cultural barriers and enablers? And can we actually somehow, and that's what I hope I can convince you as well, that behavioral economics gives you a potential tool to actually measure some of that. So gives you data, do a clinical trial on this uptake question and trying to identify these different barriers and or enablers if we do it right. So that's where I want to spend the next 10 minutes or so. So let's start with technologies, and 2 out of the 3 people that are on the program committee I can put up on the slide as well. So we worked with Dietmar Hutmacher, who's a material scientist, on new technologies, in this case around breast augmentation, and the uptake of these type of technologies by practitioners, by patients, and we also looked at the role of nurses as the in-between type of group, and actually asked, you know, are there biases? Who actually makes the decision? Who thinks about who makes the decision? Do patients and doctors are on the same page when they say, well, this is the decision that is made by the patient and the doctor only informs the patient? How do they perceive consultation? That's the type of work that we did there. And I find that quite interesting as well to think, when we talk about health equity, to actually think a bit more carefully about that. What are our perceptions there? Can we actually get an idea what happens at that case? Over coffee, we talked about experiences in private and public practice. So I'm the economist. I asked, what do you do as a practicing health practitioner? And it was quite interesting to hear words like health literacy and how patients engage in the 2 different sectors. So there is a lot of causal evidence. Can we actually more carefully understand that? And if we understand that better, can we then think about ways to deliver health services that take that into account, and maybe get the right resources there. Together with Gerald Holtman, we actually, and the Yarama Community Health Service, Gurini, we currently waiting for an outcome on an AAHMS grant that actually tries to look at enabling the community health services to deliver, in this case, endoscopies and colonoscopies that usually can only be done in a hospital setting, in a community setting, to try to understand what does that do with the barriers to actually engage with preventative health measures. And it came out of this idea that a former, actually the same person that told me about welcome or acknowledgement of country, moved from QUT on to be the manager of the Gurini Health Service, and she talked to me about this type of problems. We did before work on education, and her point was to actually say, what can we do to reduce these barriers? Can we use some of these behavioral insights to better understand them? And together with her, we on the one hand look into this technology. On the other hand, we look at RHD testing and RHD engagement with advice. And again, what are the technical barriers? Where can we use technologies better? What is the role of our financing these services? The remuneration, what are the incentives, the financial incentives to deliver these services and to engage with that? But also, what are behavioral biases? how can we better understand that? How can we engage? That's the term that behavioral economists or behavioral scientists, inside researchers like to use. How can we engage in choice architecture to actually help all these parties to make better decisions for themselves, but in particular for patients to achieve better outcomes, right? And can we then use some of the economics to actually try to document that? So that's technology. All of these technologies are great. I think all of them can play a role. The last part is the program lead in the health program at Best, Ross Crawford. I think this is just supporting knee and hip operations, surgery robots. But we talked with, or we work with the Jimison Trauma Institute as well to actually use some of these technologies to be applicable in remote communities. So again, technologies that can employ, that can support health delivery in remote communities by connecting it to expertise that may be concentrated in urban centers. And again, you know more about that. So we have technologies, and how can we look into them? If we look at the economics, very quickly, that's where I actually started out. I was interested in lots of complicated problems in the world. And economists always said we are not perfect decision makers, but a lot of economics builds on this assumption we know everything and we are very smart, at least economics 20 years ago. And I was just then interested to ask the question, will experts always deliver good service or not? And I more or less worked for the first 10 years of my academic career on trying to understand economic incentives and what's the regulation that's needed, what's the institutional setup that is needed to achieve efficient outcomes. And then I thought, well, this is all nice, but I'm not making decisions like an economist, and even though I am an economist, why would I expect that doctors or even patients make decisions like what economists assume? So we started to look actually at behavior, and we found out, yes, some people are actually pretty much driven by profits, but others are driven by the right intentions and want to do the right thing, have something like preferences for efficiencies. Others very much care about distribution. When I talked to media people at the time, we talked about that there are a lot of people, and it's about a third of the population, pretty robust across different type of studies, that have Robin Hood preferences. If you deal with somebody who's richer, you like to take from him and give to yourself. If you deal with someone who has less, you actually do show much more care. About a third of the population, pretty consistent. Anyway, we looked at this type of trying to understand incentives, and I still find it important because in certain areas we know incentives are a very strong driver of behavior, if only to send the signal that someone cares about it. We talked about the role of government in this space. And I think if government chooses to provide incentives, at least it's a signal, hopefully, that they have good reason for that. I think we heard as well that that has not always been the case. I'm a little bit more hoping that people are good and hopeful there, because otherwise it's, I think, too daunting to work on that. So that's the economics. Can we understand the role that financial incentives play in this space? And we have done a little bit of work on that, but for now, a lot of the work is really combining this, trying to understand what part of the variation, the outcomes we achieve, can be explained by economic and legal conditions, incentives, the institutions that we have in place, and which is then or needs to be explained by behavioral patterns. There we go. That's just the way how we think about these type of situations, not particularly exciting. Oops. What I find more interesting is to actually then start and go out and look at data. And this is the first type of example of a health economics, or not a behavioral health economic study. It's not a typical health economic study. we actually try to understand, and I found that a good example for health equity, what happens at pharmacies. And we more or less did an audit study. We sent students out that were asking for treatments. Either they had unprotected sex in either the last 24 hours or 3 or 4 days ago, or I think we looked at eye infections and worked with colleagues in pharmacology on that. And we more or less saw where incentives play a big role. A lot of pharmacists, even though they should have sent the patient directly to a doctor, were willing to sell something before they sent them to a doctor as well. So there is some incentives do matter, and they actually affect health outcomes. We looked a little bit of to what extent this was amplified by for example, health literacy, and yes, you find some sort of effect, but it's pretty robust across across that. On the upside, very little where we would say this was over-treatment that was damaging to the individual. So it wasn't all bad, so to say. So that was the first one, very much directly looking at what can we learn from the institutional setup. Do we find some evidence, and what does it mean for the provision of healthcare? The last thing that I want to talk about is this work around behavioral economics or nudge, and I think you all have heard about that. What that more or less does in a nutshell, the 20-second version of behavioral economics, maybe 40 seconds. Daniel Kahneman wrote this book, Thinking Fast and Slow. Before that, he worked for 25 years on this type of behavioral biases. For you, Don Redelman may be a big name. I think he was an early person in the health space to talk about biases and the role of biases. Atul Gawande is another big writer in this in this space of health that I see quite frequently. But the idea is more or less what Kahneman and Tversky's work did is we have behavioral biases. Our decision making isn't perfect, and they document plenty of those. They're quite systematic. And then what Carl Sunstein and Richard Thaler did is they said, well, if we have these systematic biases, we should think about policies and how they lead us to decisions and engage in this choice architecture, right? We can help people to make better decisions for themselves. Richard Thaler then went on to advise the UK government under David Cameron with the BIT team. You may have heard about them. Carl Sunstein worked with Barack Obama, and there was a big behavioral economics team pre-Trump in the White House trying to actually use behavioral insights to inform policy. That's the idea. You can go through different biases. This is just one of the diagrams that we developed at one point in time. And the idea is you look at decisions and ask yourself what type of bias may apply in a certain situation. And then we can do research as well to find whether these biases affect decisions in this space. I give you one example of that. This is one example on the new materials, new therapies work that we talked about. And it just documents quite nicely. And interesting enough, that was the case for health practitioners as well as patients in a slightly different way. If you present the information slightly different, it's the same information, but you present it what we call a gain frame, a positive frame, or you present it in a cost frame, exactly the same data, and just talk about whether you get more. So I take one outcome as a reference point and say, compared to that, you do a lot better. Or I take the other one and present it as a loss frame, and you get different results, what type of therapies are chosen. Independent, whether it's a patient, a doctor, or a nurse. In that case, this was actually quite interesting to see that. That's one way to we look at that. I thought I'd end with a good news story, because we are I think getting close to my time limit. I don't know how I do. We recently did a study right across there with the emergency department of of the PA. We had about 2/3 of the triage nurses participating in our experiments. It was funded by the Emergency Foundation. One of my students got a grant for that. And we found actually in the population of these triage nurses a lot of evidence for all the different biases. By the way, very much in line with the literature, same as for doctors or other medical practitioners or the general population. But we found as well that in the triage context, they do actually pretty well not to be affected by these biases. So that was great to see. And it was actually quite interesting because in this literature, we usually do have a lot of evidence only if the biases lead to negative outcomes. We actually we pre-registered the trial. So we worked on the literature and said, look, let's see how much actually a well-trained workforce means in that. It was a very positive outcome. So a lot of other effects as well. There's still a couple of things that are worthwhile looking in, risk attitudes and so on. But I think it's a positive note to end upon. Good training in providing health advice can actually lead to better outcomes. And that may be one of the parts that we hope we are able to work with in community as well to achieve similar better outcomes. And yeah, that's where we are with the work that we do at the moment. Thank you.
Well, thank you, Uwe, for that fascinating description of the benefits that behavioral economics can have. We do have time for probably one, maybe two quick questions. Are there people in the audience who do have things that they'd like to ask? Or Simon?
You may not be able to hear me. Sorry, you may not be able to hear me, but hopefully you can now. Just in relation to that last study that you talked about, it's a really interesting result. Can you tell us about the way that you made that judgment that they were no longer affected by cognitive biases, and how good is that measurement?
Yeah. So what we do is we run more or less vignettes tests that are quite well established and validated in the literature for these biases, and that gives you the distribution of bias in the population. And then we developed with the teaching team for the department, again, cases that we asked the triage nurses to evaluate. And the same, they evaluate as well the reply of the triage nurses. So that's the way how we set it up. So we really look at the cognitive biases separately from the evaluation study. So in the literature, what people have done, and I think that's where I would say it wasn't a smart design, but that's up to others to decide. People have always mixed it up immediately. We actually wanted to first document the presence of bias and then see whether it affects this specific decision.
And there's maybe one more question in the middle at the back.
Thanks very much. I'm Don Nutbeam from University of Sydney. So how do you respond to a common criticism of behavioral economics that it focuses attention on individuals and their behaviors and offers little consideration of wider social and economic influences on health? And as a consequence, people who best respond to behavioral interventions are often those who are better educated, have more access to resources and so on. There's a risk it could actually exacerbate inequities in health. Now, I know that's me paraphrasing what is a complex argument, but I think it's worth exposing in a session that's focused on equity.
So I think and this is very often the discussion I have when I talk to government. Government very often thinks, can you design for us a campaign, right? And that's exactly, if I do another information campaign, you need to have basic literacy already. I find, and we work very much, we heard this word co-design this morning a lot. That's exactly what we usually do as well. And that's why I showed you this technology for the GPs doing colonoscopies, because I find that's actually a different approach, right? So it is a nudge in the sense, as I say, you can do, if you need to go to that stage of the process, you can actually do it in a more normal environment. You don't have to go to the hospital, which is maybe more alien, for all of us alien, but I could imagine in this type of situations even worse. So it is actually broader. I was actually wondering whether you go the other direction. In the UK now, you have a lot of discussions that behavioral economics is just manipulation. You just use psychological insights to maneuver people in a certain direction. And I find like it's slightly different, the approach we take. That's why I emphasize sometimes the economics. We always talk about you work with experts in the field, with the economists to have a benchmark and then try to see how close do you get with this behavioral economic intervention to the benchmark. And that could tell us as well, and that's where I feel this is useful also to address health inequity. It could tell us as well which type of groups engage with a certain nudge. And very often actually I have a colleague who recently did a big project around different people using public transport infrastructure. Very often we end up with recommendations that say, well, there's this group of people. For them, you do best an offer like that. For this group, you could do an education campaign. For this group, you do what we call a social nudge. You give them more of an idea what other people do in community, because people engage slightly different. And then you have the data to more or less show whether it does work or not.
We might have
in the ideal case.
We might have to move on, but thank you.
Yeah.
Thank you very much, Uwe, for that fascinating presentation.